Yeah, we'll start. Good evening, everybody. Welcome to the next edition of the Resident Smart Learning Program. Today we have the topic on penile prosthesis, which will be dealt by Dr. Raman Tanwar. And over to Dr. Rajesh Sood for his opening remarks.
Thank you, Dr. Keshav. Good evening, everybody. We welcome Dr. Raman. Raman is a renowned men's health specialist, and also he is an eminent urologist and special interest in sexual medicine. He is he is looking after the men's health subspecialty. Not only that, he is in the IMA standing committee of on men's health, and also he is the secretary of Men's Health Society of India. So, who can be the better person than Dr. Raman Tawar to cover this topic? This is a very important topic today, and part of a distant learning program for residents. And as we know, we had been discussing, now COVID is there. Again, pandemic second wave is there. Our chief minister in Delhi is saying it is fourth wave. I don't know. But the one thing is clear, that we are more and more dependent for resident program on this kind of distant learning programs. And Raman has always done justice to the topic which is given, and today is his teaching lecture. And he is eminent teacher, which he has authored several books. So with this, I have taken much time out of Raman's quota of time today, and I will like Dr. Raman and with this program of Indian School of Urology, Urological Society of India, important program, to be ready for the deliberations, and I give it back to Dr. Keshavamurthy.
Thank you, Professor Sood. I now hand over to Dr. Arun Chawla for the introductory remarks and to introduce Dr. Raman Tanwar.
You are muted, Dr. Chawla.
Thank you, Dr. Keshav. It's indeed a privilege to introduce Dr. Raman to our august viewers. Many of the young residents who probably have joined during the COVID times may not be knowing Dr. Raman Tanwar, and many would be thinking that they'll be probably encountering a very senior faculty who will be little in a different age group, and they'll be, I am very sure, will be surprised to see him taking a class on a very important a surgical topic. Dr. Raman Tanwar, in a brief, is to introduce to you all. Let me say, is a minimal invasive surgeon who specializes in urology, andrology, and endourology. And as Dr. Rajesh Sood was saying, adding feathers to his credential, he has written and edited 5 books on general surgery, including urology, with more than 100 publication and presentation at various national and international conferences. He is one of the very few trained fellows in the area of men health expert in this country with international experience. He has been awarded for his academic excellence by British Medical Association, Delhi Medical Association, Indian Medical Association, Urology Society of India, Delhi Urology Society, and many other reputed organizations in the field of urology. He has numerous gold medals in the field of urology for his outstanding academics, organization, research, and innovation. He has, along with the other faculty, organized many international national conferences in urology, including World Congress on Men's Health and World Meeting on Interstitial Cystitis and Bladder Pain Syndrome. At present, he is head Department of Urology and Andrology at Eurocenter Jyoti Hospital, Gurugram, as well as heading the Department of Urology and Endourology at C.K. Birla Hospital, Gurugram. With this brief introduction, I invite Dr. Raman Tanwar to please start the proceedings for our viewers.
Can we acknowledge that Dr. Tohit, Secretary of the Bangladesh Urology Association, and his colleagues also logged into this program now. Welcome, Dr. Tohit.
Welcome everybody from Bangladesh and other SAARC countries. Yes, Dr. Keshav.
Thank you very much, Dr. Keshav, Secretary General USI, and Dr. Rajiv Sood, the Chairman of Urology Society, Indian School of Urology, and Dr. Arun Chawla, and today's presenter, Dr. Raman Tanwar. And thank you very much for sending the link. I hope our so many senior colleagues and also the resident will join. Thank you very much.
Thank you, sir. Thank you for joining. Over to Dr. Raman for his presentation.
So thank you very much. I hope I am audible, and I'll just share my slides if everyone allows. So I'll be sharing my entire desktop itself, sir, so that we can have those videos which were probably not there, can also be seen, which are not a part of the slide. So, sir, I hope we can see the slides. With this, I would like to first thank the Indian School of Urology and the office bearers of it, and the Urological Society of India, the office bearers of the USI, for this opportunity. And today's topic is on penile prosthesis, which is a niche subspecialty of andrology again, which itself is a subspecialty of urology. And this talk I would like to dedicate to 25 years of the Indian Shah implant, which is there in my hand. So what I will be doing in this talk is just to make it more interactive. I will be switching off from the screen to the camera so that I can show you some things which are live, which are not just there in the presentation, which I cannot probably just put into words. And I think that will be a great help to our residents. So the learning objectives of the talk today are to identify those patients who need a penile prosthesis. So we have to make the correct identification of these patients. Then we have to manage the expectations of these patients, because sometimes, when you talk about implants, there's a lot of literature available, and sometimes patients would over expect from an implant. And we have to set the expectations right for the surgery to be really successful in the true sense. That is a happy patient, a happy surgeon, and a treated disease. We will understand in this talk what are the various types of penile prostheses which are available. And we'll be seeing a lot of them here in my hand live today. We'll be able to prepare the patients for the surgery. We will learn what are the common approaches and how the surgeries are done. And then we'll understand some complications and just the basic management of those complications. So that is what the objective is. So the overview of the talk is, first I'll introduce the implants to you with a small brief history of how we've reached to these wonderful devices with 50 years of hard work. We'll talk about what are the indications, the types, and how to prepare, and what are the approaches to do the surgery, and then complications. And then lastly, we may talk about some special situations if time allows, or we will take them as questions. So let me begin with a little boring part, but something which is very important to know, because once you will only realize the importance of these modern devices once you have seen what hard work has been put to make them so effective and simple and consumer friendly or patient friendly, I may say. So it all started in 1500s and later, when cartilage of the rib was actually used to put inside the penis. So what they did, as you can see in the diagram, is that they put it in between the two corpora cavernosa of the penis. So that is where it started. And then there were acrylic prostheses that were made, and then rod implants which were made. But what we know today as the modern day implants, probably the credit would go to Scott and Small Carry-On. So basically, Scott made the first inflatable implant in 1973, followed by the Small Carry-On sponge-filled semi-rigid implant, which was the rod implant, the version of our modern malleable implants that was done in 74. So this is a brief history in time, and we would realize that it started quite way back in 1500s, and in 1936 is when some sort of a real thing was put. Before that, there were just wooden splints which were used, or wooden pipes which were used to facilitate the urination and all those things. And now we've reached a point in 2021 where we have king-free tubings, where we have no-touch techniques, where we have concealed reservoirs, where we have silver-coated, silver-impregnated nitinol coat, natural feeling, silicone coatings, PVP coatings, antibiotics, laden on the implants, and so much more that makes it so simple to advise the surgery to the patient. So let me start with the first part of the talk, which is, who is the patient in which I will give an implant? Because we get a lot of patients otherwise who come with erectile dysfunction, and some of them would be so disturbed that you may want to offer an implant to them right away. because maybe they have lost all their youth thinking about erectile dysfunction, or they have a failed marriage which is ending up in a divorce, and they are in so much of a psychological situation where they anyways will not be able to get an erection. So you have to understand that the penile implant is mainly for a patient who has a refractory erectile dysfunction, which means that you've tried everything, you've given medicines, you've understood the cause well, you've investigated properly, and whatever has been given is not working well for the patient, including medications, intracavernosal injections, and experimental therapies if you may want to give to the patient. Apart from refractory ED, I would say one of the most common indications for putting a penile implant in the case of erectile dysfunction is a end-stage lifestyle disease, wherein it has been a sequelae of diabetes, a hypertension, or a penile attack, as we can say, or ischemic penile episodes, and they have led to a refractory erectile dysfunction. There are certain special situations also where you may want to put in an implant. For example, after a new phallus has been created, maybe because of traumatic amputation of the penis, or maybe because of gender reassignment where a female is being turned into a male, or maybe there has been a long duration priapism, or maybe an acute setting where the patient has presented within 3 days of the priapism and you want to help the patient. And there's some cases of very complicated Peyronie's disease. Apart from that, there are very numerous indications, I would say, where there'll be big question marks around it, but you will be able to justify putting an implant if it is actually refractory and there's nothing else that can be done to help the patient. You have to understand that many patients would also want you to put it in them without being the deserving candidate. So it's very important, as many of our seniors would agree, that implant has to be put into a deserving candidate and not just into anybody with erectile dysfunction. So we have to understand more often than not that who are the patients whom we should not be giving the penile implant. So I get many of these patients. So I just want you to, as a resident, understand the mnemonic curse, which means that somebody who is compulsive, who wants you to put an implant, somebody who has unrealistic expectations from the implant, revision cases who just want some minor corrections and they want to go for the implant again. Patients who are shopping for surgeons, finding somebody who can put the implant in the best possible way with guarantees. Patients who feel so entitled that they can run into their OPD anytime without appointments and misbehave with you, with your staff, all these kind of patients. Patients who are denying any complications that can arise out of implants, who have basically got their own way of thinking about implants, and psychiatric patients. So we get such things, as I've mentioned in the slide, that said, hi, I'm an unmarried 22-year-old guy and I'm not getting any erection since yesterday. I want to fly in today, doctor. I've heard your name. I want to come in for an implant. Now, these kind of patients are somebody who should not be offered an implant. You have to understand the pathology first before you offer it. So I'll just kind of briefly expand the curse mnemonic, which is compulsive or obsessive patients. Somebody who's penocentric, he wants his penis to be very big. He wants his penis to, have a bigger girth, a bigger length. Somebody who is pathologically observing his penis, yesterday morning there was no morning erection, day before yesterday morning there was little morning erection. So somebody who is so perfectionist and detail oriented and who is not flexible at all. Those are obsessive and compulsive patients. They are penocentric patients. We should be very careful when we offer implants to these patients. Somebody who is unrealistic, he wants that his implant should just be guaranteed and there wouldn't be any complications. He's very, very optimistic about it, as if it was just a toy which is being inserted into him. Somebody who's seeking very high specific set of outcomes. For example, the revision cases where they do not understand that revision is not a simpler surgery as was the first implant. Patients who can deny and denial phase, they have exaggerated memories of the prior sexual characteristics, and they would compare their implant with what was there when they were younger. So these kind of patients are also something that you have to be scared of. Somebody who is doing surgeon shopping, of course, who can just quickly criticize the surgeon, asked about what is your experience in putting an implant, since how many years have you been doing implants, or how many of these particular model implants you've done. These kind of patients, who think that this is just a mechanical job and not an art, have to be, taken very, very cautiously into the theater. Somebody who's entitled, patients who are psychiatric, these are the patients. I would also make sure that, whatever patient I'm putting the implant on has the expectations on the ground. So somebody who is coming from very far off, maybe a village, who does not want to come to the hospital again, thinks that implant is just a 3-day thing and then he'll be fine absolutely, would be somebody where I would be very, very cautious in putting an implant. Similarly, patients who have spinal cord injury. Now, these patients have nerve problem in the sense their sensations are lost. So sometimes, the implants, they can dangerously erode out because they don't have the sensations as such in some patients. Somebody who's stationary and would not be too much mobile, somebody with reduced distal blood circulation, where if I make incisions, the glands may become necrosed or the blood vascular supply may be compromised. Somebody who's not very good at maintaining his hygiene because we want infections to be at bay. Somebody who's immunocompromised, somebody who has a prolonged catheter in situ, and somebody with substance abuse, because these are patients where we can land up in trouble. So we have to make sure that we specially counsel them with some extra time at hand before we go for an implant, and we take all the possible precautions which we will talk about in the lecture today. So as my experience of the last decade has told me, expectation management is the key in managing patients with penile implants. So you have to tell them that this is a process. This is something which is not a part of the body, and it will not be natural. It can be very close to natural. Maybe you will find it better than natural, but it is not natural. And prosthesis cannot be more than natural. It has its limitations, and diseased penis also has its limitations. So we have to explain the patient that the implant will only go into the corpora cavernosa of the penis. It will not go up to the glands. Many patients don't know about it. They would feel that it will come to the end and it will make everything rigid. So you have to tell them that we are putting this implant into the 2 corporal cylinders, and glans is a 3rd cylinder where we will not be putting the implant. So it will only support the glans, and foreplay will be very, very much required. And even phosphodiesterase inhibitors may be taken as a support to improve the outcomes of the implant. You have to also tell them that if there has been a long-standing erectile dysfunction, then those corpora may be shrunken in size, and you may not get results which were there when you were probably 15 years or 20 years old. And you have to understand and accept those things, that your corpora would have fibros, your things would have fibros, the skin would have changed, everything would have changed over the years. You have to make them understand that a lot of things will depend on their own anatomy. End of the day, we cannot give them too much length, too much girth. We can only put an implant into the natural cavity of the implant, which is the corpora cavernosa. Although there are surgeries which are being done, for example, the tip, which we may discuss in the discussion, where we can increase the length of the penis as such, but these are high risk surgeries. They probably are not giving the results uniformly all across the globe. Some places the studies have given good results, at other places they have miserably failed. So this is certainly an experimental area at this point of time. So we have to probably give a disclaimer to the patient, like the one that I have made for my patients. And if anybody wants a disclaimer, I'll be happy to share it with them. We sign this in front of the patient, do a video counseling for the patient that we have told everything, and make them sign in front of us and in front of a witness. This is how much serious it is to manage the expectation of the patient. Coming back to the implants, the interesting part, coming back to talk about these rods which are there in my hand. So we find that as we move from the west to the east, the American implants, because they're covered in the insurance, usually we'll find that more and more usages of inflatable implants. Maybe 90% of the implants put are inflatable and 10% are rods. When we move to the European subcontinent, we'll find that almost half and half ratio is there, which means there'll be more patients who will be probably going for the inflatable. Maybe about 60% and 40% of them would go for something which is rigid, like this rod. And these are called malleable implants. We'll be talking about all the implants very soon. And as we again move towards the Middle East, more people would be going for a rod-based implant than an inflatable implant because of the cost factors. And when we come to India, probably I think the ratio is about 90 to 95% that people would go on for something like a very genuine and very good implant, indigenous. And we'll talk about this. This is the implant to which our talk is dedicated today. This is the Shah's Surgical Indian penile implant. So as we move down, we're finding more and more, because of economics changing, the patients are going towards a malleable rod. So let's talk about the types of prostheses. And just to give you a brief idea, there are about 4 major types of prostheses. So there are malleable implants. These are the ones which do not have any water mechanism in them. They basically are solid rods. So they are silicon-based rods, or maybe maybe certain other material-based rods, and they basically just fit inside the corpora cavernosa. Once they are fit, the penis will always remain erected. It can be bent down in certain situations if the implant is with a memory, but in implants which are without a memory, basically it will remain erect and only has to be concealed in a tight underwear or a tight undergarment, or to be worn on either side of the thighs or maybe on the abdomen. Then we have the other category of implant, which is called the inflatable implants, such as these in my hand. Now, what happens in an inflatable implant is that basically there's a pump which is connected to a reservoir separately, and from water from the reservoir goes through the pump, and it basically inflates the cylinder so that when the patient gets an erection. Now, these cylinders are placed inside the corpora cavernosa. Now, once the patient is done with the sexual activity, he will press a button which is there on the implant. And when the button is pressed, the implants will deflate and they will lead to a loss of the erection, and the penis will return to a flaccid state. So the advantage of these inflatable ones is that the concealment becomes suddenly much more better. And therefore the patient acceptability also becomes much more better. But as we will realize that all implants have their own place, not just because of the economics, but because of the various other advantages that each of the sub-variety of implant offers. So that is why we have all of them available in the market, and they are doing well from the different aspects of patient demographics and economics. So let me just pause here for a while, stop the sharing of my screen, and work and actually in a live fashion teach you about the various implants. So this is something which we call the Shah's Indian Malleable implant. Now, as you can see that this is a silicon-based rod, and we have quite a few of them here. So you will realize that this basically is a rod made of silicon with different hardnesses. So this is the tip part, which is quite, I would say, soft. So this is measured in the terms of Shore. So this is 25 Shore silicon. The middle part is the rigid part, which is more difficult to bend, as you can see. And this provides the rigidity to the shaft of the penis. And then there's this hinge part, as you can see that this is easily bendable. This again is 25 Shore. And then we have the back part of the implant, which is about 50 Shore in the hardness. And then we have a rear tip extender to the implant. So this is what a Shah's penile prosthesis looks like. This has been devised by the father of andrology, I would say, of India, Dr. Rupin Shah, and inspired from the ideas of Dr. D.D. Kaur when he first brought the implants to India from the West. Now, basically, as you can see, this Shah's penile implant, it has multiple sheaths. So basically, what means is that we can remove the sheath like this, and we can get a thinner implant, as you can see. Now, this is thicker, this is thinner. So if the corpora size is less, then we can, of course, we can remove this outer part of, or the outer sheath, and we get a thinner implant. Also, we can cut it from anywhere we want and then fit in the rear tip extender into this, so that we can customize the implant to as much as we want and exactly to the shape of the penis. This is another Shah's implant which we have cut because during the surgery, probably that surgeon, whoever put the implant, thought that he was not able to go well into the most distal part of the corpora cavernosa. So the beauty of Shah's implant is that you can trim it from anywhere to fit it into the penis exactly in its same morphology. So we will be talking further about Shah's implant later, but then I just want you to understand the beauty of this implant, and this is very, very cost-effective implant, and probably it is the cheapest implant available in the world. So anybody can afford this implant if they have refractory erectile dysfunction. The other implant that I wanted to show you, this is an example of a malleable implant with memory, which means that when I bend the implant, it remains bent. Okay, so compared to a Shah's implant, where if we bend it, and when the penis comes out of the underwear, it's going to stand straight and erect. This remains bent if you want it to bend. So there are various implants of this type, which we will be discussing in these slides further. But this is a malleable implant with memory. Of course, this is a US-based implant, and we can again trim the parts based on the length of the corpora. And then it also has the rear tip extenders. So wherever you cut, there you can put this rear tip extender and you can fit it inside the corpora cavern. So this is a bendable, malleable implant with memory. Then we come to the inflatable penile implants. So inflatable penile implants, they have again two or three parts. So first we will talk about the two-piece penile implant. So this is not a two-piece penile implant, but just to demonstrate, of course there's a video also which I will be just portraying right now. So this is a three-piece penile implant. So as you can see there, one of the pieces is the two hemiprostheses. Hemiprosthesis means that they are half of each. So this is called completely the process. These are two hemiprostheses, and these go inside the corpora cavernosa. So this thread that you can see is basically used to pull the cylinder out from the glandular side so that it can fit inside. And there is a connection of these two inflatable rods with the scrotal pump. So when you pump in, this scrotal pump is basically placed in between the two testes and the scrotum in a subdartos pouch. And when the patient wants to have sexual activity, they would just simply press on this pump a few times, and you will see that the implant becomes more rigid. And whenever the sexual activity is done, there is a small button here which they will have to press. Again, they can feel this button. And then basically all the fluid will be going down. And as you can see, this has been completely deflated. And now the penis will hang like it was. Now, the third part of this three-piece prosthesis is the reservoir, which I don't have right now, but it's basically a balloon, a spherical balloon, and we can see some pictures of it subsequently, which goes into the abdomen. So this is a place from where the fluid will travel down into the pump, and then from the pump, it will travel into the prosthesis. So this is a three-piece penile implant. And let me just run now a video of the two-piece penile implant also, so that we can see them all live in action. So just excuse me for a minute for that. So I'll be unboxing now in front of you the two-piece penile implant. So I hope all of you can see this video. So this is the kind of packet which it comes in. And basically I'll be doing it in front. This is a separate back-end trolley. It's not a part of the typical surgeon's trolley. So here you find that this is pre-filled with a liquid, and then once you kind of bring it out, you will feel that this is how the two-piece looks. So I just want you to understand that the two-piece has two parts within the implant itself. The reservoir is in the back of the implant, and the front part is the one wherein the fluid fills. So only half of the implant gets deflated, and the other half is the one which holds the water. So there's no reservoir. So the reservoir is in the back end of the implant itself, and the pump is also filled with fluid. So basically, there is a cycling of fluid which happens from the back end through the pump into the front end of the implant, leading to the erection, which we will also see subsequently. So this is how it looks. This is the pump. These are the two inflatable hemiprostheses, and this makes it the two-piece. So now what I'm doing is I'm bending the implant to pull the water out from the front part to the back part. This cycling takes a little while because this is something which is unlocked. Now let us move on to the other video wherein we will demonstrate about the implant further. So I hope you can see the video. So let us just see how it works, okay? So I'm trying to fill in the water. It's coming from the back end, basically, to the front end, and now it's become rigid. Now what I will be doing is I'll be shutting it down or bending it. The patient will be bending his penis down for 12 seconds. And in 12 seconds, what will happen is that all the water will go back from the front part to the back part, and it will become loose. So this was about the various forms of penile prosthesis. Now let me get back to my presentation. Right. So I hope you can all see the slides. Sir, I would need some input from Arun sir whenever there is a problem in seeing the slides. So now we're going to basically talk about the various processes which are available. So here are a few companies, which are available in the world, and most of them are also now luckily available in India. And from that perspective, we have Boston Scientific making the AMS implant, the American Medical System implants, which are one of the most successfully running implants in the world. Then we have Coloplast. Then we have Argentina-based company, which is not there in India yet, but we have got some implants from them. Patients have brought them and got them implanted through me. So this is called Promedon. And then we have ZSI, which is a Switzerland-based company making implants. And we have Rigicon, which is a US-based company, which is, so Boston, Coloplast, and Rigicon are all US-based companies. ZSI is Switzerland-based and Promedon is Argentina-based. There are many others which maybe even I am not aware of, but they don't have a global presence as yet. So we are basically going to talk about the common models. So when it comes to the malleable implant, the most commonly put is the Surgiware Shah's implant, which we have talked about, the Glorious implant. We'll also talk about it further in detail. The second implant is the Coloplast Genesis implant. Now, this is not formally available in India officially, but basically patients can bring it in and it offers an international warranty for Coloplast. Then we have ZSI 100 implant, which is the Switzerland-based company. And this is one of the pictures of the ZSI-based implant. Then we have a Rigid 10 implant, which also brings a Rigid 10 hydrophilic version. And then we have the Boston Scientific Tactra, which I showed you in my hands, the one which again bends and has a memory. And then we have the implant called Tube from Promedon. So as we would understand that there are two main types of classification, this one without a memory and the one with a memory. So all the implants which have a memory have some sort of a wire in them, which can keep the implant bent. For example, the Coloplast Genesis has a medical silver wire. The ZSI 100 has a medical grade silver wire braided. The Rigid 10 again has a medical grade silver wire. Boston Scientific from Tactra has a nitinol wire in it. And Promedon Tube also has a medical silver wire. So these implants are not detectable in the airports when because this will be a common question that patients will ask you, can we detect these in the airport? So they would not be detected by the screen. Also, they are MRI compatible implants. So basically patients can go for an MRI even when they have these implants. So these are some things which you should know. So, so just to elaborate that further, so we have two models when it comes to the Shah's prosthesis. One is with hinge, which means that there is a part which is bendable, and the other is non-hinge. So it's called OH. So it's for a certain particular group of patients. For example, patient with spinal cord injury, you can put in a very, very soft implant because there are soft, medium, and hard versions available for it. But OH basically doesn't have a hinge, which means that it is going to be completely erect. It has to be bent down by force only. Whereas the with hinge implant, it can be easily bent and concealed. Then the Coloplast Genesis we talked about. The ZSI 100 implant, it has some specific implants with it, which are not there with other companies. For example, there's a female to male implant, wherein we don't have the rear tip extender. We just have a plate with 4 screws, and you can fix it to the pubic bone, so that in a patient who is a female patient has undergone a neophallus, there's fixity to the implant, it doesn't protrude out. So it's a very good thing for patients who go for gender reassignment. Then we have PVP coated implant also. So we have seen that implants, they have a big disadvantage of infection. That is the most dreaded complication for most prosthesis surgeons. So this can be reduced by coating the implants with antibiotics or making a hydrophilic coating which absorbs antibiotics. So the LSI has this PVP coated, and then we have the Rigi, which again is hydrophilic. Then let's come and talk about the inflatable implant. So we've already discussed about the AMS Ambicor 2-piece, and we've already seen the AMS inflatable implant 3-piece. Now I want you to understand the 3-piece also has various varieties with it. So basically, when we are doing a penile implant surgery, sometimes it may be a new case, sometimes it may be a revision case, and every patient would have different anatomy inside in their corpora cavernosa. So what the job of a surgeon is to basically understand that anatomy well, and then put in an implant of the correct length, whatever is the maximum possible girth, and whatever works well for the patient. So basically, it's not the patient who is making the decision himself. It is a team effort where the surgeon and the patient are together sitting down and making a decision on what implant has to be put. And once that decision is made, then the surgeon has to ensure that when he goes intraoperatively, he measures the corporal cylinders correctly, measures the girth correctly, and gives the patient the best outcome possible by giving him the best possible size of the penis. So that's why there are different models. For example, CX model from AMS is AMS 700 is the name of the model, and then there's CX written after it. So this basically is the implant which is most commonly put in the Indian patients. Then we have a special CXR implant, which is for revision cases or patients where there has been a removal of the implant or an infection or a priapism, and the inside of the corpora is very tough and it's difficult to put in the regular size of the implant. So this has a narrow base and it has a lesser girth, and we will be comparing it in the chart subsequently. There's another implant called the LGX, basically, which also increases the length of the penis. So this is something which we should know, that the implant can help in maintaining the length and increasing the length if we are able to put an LGX implant. But you have to understand that LGX implant requires the corporal diameters to be above 15 mm, because it cannot be put if the corporal diameters are less. So basically, it's not possible in every patient to put an LGX, although when patients are learned, they will ask you to, I just want the LGX. But you have to make them understand that Indian penises may be smaller than those of African patients or the Western side. And it may not be possible to guarantee that you will be able to put an LGX. That's why whenever you are putting an implant, there's a person from the company who would have all the models available for you so that you can measure it right then and put in the right implant. Then we have the Coloplast, which makes the Titan and Titan Narrow, but these are not officially available in the country as yet. Then we have Rigicon, which has Infla 10A, which is the standard CX sort of version. Then there's an Infla 10A Narrow, which is the CXR sort of version for the revision cases, for the smaller penises, for the ischemic penises, post-priapism cases, post-infection cases. And we have the Infla 10AX, which is like the LGX, which also can improve the length of the penis. Then from the ZSI, we have the ZSI 475 and the ZSI 475 FTM device. The FTM device again is an inflatable one with that plate so that it can be hooked into the pubic symphysis. So this is a comparative chart of the two commonly available companies, Boston and Coloplast, and I'm sure you will find this chart also in your textbooks. So this just gives us the various possible lengths which are there. What are the maximum lengths and girths possible? What are the materials that these implants are made of? And these are things which are good to know when you're deciding the length. And so let's talk about the real thing, the one which our Indian residents would be subjected to put most commonly because of the the fabulous nature of this implant, and also the economics of this implant, easy availability of the implant, and its indigenous nature, which is the Shah's implant. So basically, I've just made a diagram here about the Shah's implant, and as you can see, there are 4 parts of this implant. So this is the soft part, the front tip, and then this is the hard part, the middle part, which goes into the shaft of the penis. And then there is this hinged part, which is again soft and can be easily bent. And then after that, there is a hard part again. You can say it's a medium hardness part, which is completed by a rear tip extender. Now you can see that all the Shah's implants, they have 2 sheets extra. So if we look at the implant as such in general, for example, the one which is in my hand, this is quite this is a WH15 actually, which is there in my hand, and this, as you can see, is it's quite wide. It's basically the diameter right now is 15 mm. Now this is one of the very few implants which guarantees a diameter of 15 mm inside the corpora, right? And once you remove this sheath, the outer sheath, you will get a diameter of 13 mm, and when you remove it, this one also, then you will get a diameter of 11 mm. This is for a WH15 model. If we compare it with the WH11 model, which probably this is the WH11 model, because you can see the hinges here, right? So we'll just compare the 2 hinges. So I'm just putting them side by side. You can see that the length, this length is 15, and this is basically somewhere around 11. So this is WH11, this is WH15. And here the outer diameter that you get maximum is 13 mm and not 15 mm like in the WH15. And then basically once you remove this, you are left with a diameter of 11. And once you remove this as well, then you're left with a diameter of 9.5. And of course, you can scale it down, trim it down further, for specific difficult situations which you've never thought of would come in your life. Now, what I would like to give as a tip right now is that, when you are basically putting the implant and it is not fitting in well and you're removing it, sometimes what happens is the rear tip gets stuck inside in the most proximal part of the corpora. So whenever you're putting this implant, you should, this is a personal tip, of course, and you can basically put in a small non-absorbable stitch here so that whenever somebody has to remove the implant, or if you have to remove the implant, maybe because it's not fitting in well right then this part is not lost in the most proximal part of the corpora. So that's a good tip, and it should come in handy to you. Also, just to make as you can see in this diagram, the most distal part, which is there behind the glans, this part is of course much more conical. So sometimes this part may become a little too wide for it to enter the entire front part of the corpora cavernosa. So what you can do is you can just shave this part off selectively, as I have done for this model, and then it makes it fit more snugly into the most distal aspect of the corpora. And this, the shaft part can be easily maintained. So this is about the Shah's implant. Now let's talk about how you prepare a patient for the surgery. So of course there has to be a clinical fitness and there has to be laboratory fitness. So clinical fitness means that of course you made sure that this patient has come and he deserves the implant. And now basically you want to make sure there are no local wounds, no fungal infections around. He can use some sort of a scrub, a betadine scrub, or a strong soap for 2 days to keep that area hygienic and clean, to reduce the microbial flora around the place. And you have to make sure that he is PAC fit, of course, and then his medical conditions are well controlled. And preferably his HbA1c is less than 7.5. Because it has been seen that as the HbA1c rises, the incidence of infection steeply starts to rise, specifically when there is the HbA1c of more than 8.5. So I would strongly encourage you not to operate on anybody whose HbA1c is more than 8.5, because studies showed that the infection rates would steeply rise beyond this point. Beyond this point, the infection rates may just simply rise from 1 to maybe 6%. So the ideal HbA1c would be less than 7.5 in case you want to operate somebody who's a diabetic. Now, before the admission, you have to optimize the health condition of the patient. You have to assess his sugar. You have to make sure that there is no UTI, or if there was a UTI, it's well controlled. You have to optimize the local skin. Before shifting the patient to the operating room, you have to make sure that the surgeon has examined the area. There should not be any intraoperative surprises. His length and everything has been measured. You use an ioban or iodine-based scrub, and you do an antibiotic testing before shifting. Then basically, before you give the incision, you have to give in the antibiotic. You have to clip the hair within the theater only. It doesn't matter too much whether you're clipping or shaving, but this has to be done within the premises of the theater only, because we don't want flora or infections to set in. Usually when we prepare for most of the surgeries, we use a povidone iodine solution. But here we found that if we use a chlorhexidine based solution, then it reduces the incidence of infections by 40%, when compared to betadine. Now, again, before implanting, you have to, kind of prepare by using flesh gloves. So you should not be, putting in the implant with the same old gloves which had, been touching on the skin of the scrotum everywhere. You can use an ioban or a no-touch technique, and then you can keep irrigating the entire cavity, the implants, the instruments with an antibiotic solution, which again we will talk about while we discuss. Now let's come on to the various approaches to the surgery. What are the incisions that you can give before for putting the implant? So this is also something that we should be aware of, because there'll be specific situations where one sort of incision would win over the other incisions. So basically we have to understand there are 5 types of approaches to a penile implant surgery. So there could be a penoscrotal incision that you could give, which is as a junction of the penis and the scrotum. Now this is the most commonly used location because of easy access to the scrotum, to the penis, and you're midway in the corpora, not too proximal, not too distal, so it's quite easy to maneuver things. And we're also kind of familiar with all the training and photos and things that we see to use the penoscrotal approach. Once you move a little more distally into the penis, when you make a incision into the shaft of the penis in the midline. That's called a penile approach, but I probably think it's an extension of the penoscrotal incision itself. Now, your penoscrotal incision can be a transverse incision or it can be a vertical incision. Now, the advantage of the penoscrotal is, of course, that you're familiar, the urethra is under vision. And because the scrotum is quite accessible, as we will see in a 3-piece implant video, so it's quite easy to insert the pump. The disadvantage is that here there's a lot of fascia to cut. So you may take some time to reach the corpora. And the reservoir intra-abdominally has to be placed with some special techniques. And it may be a little more difficult when you compare it with the infrapubic approach. Now, in the infrapubic approach, as you can see, we are just making an incision, which is about probably 2 centimeters or roughly an inch long above the root of the penis. Now here, basically you get fast access because there is not much fascia. As soon as you're done through the fat and the fascia, you are right there on the corpora. The problem is that here you also have the neurovascular bundles dorsally. So you have to make sure that, those are well protected before you make an incision into the corpora. The advantage of an infrapubic approach, of course, is that you're reaching the corpora very fast. So maybe you're doing the first surgery faster. The incision, of course, is much smaller compared to a penoscrotal, but that you can also control otherwise. And then the reservoir placement is quite easy because you're just in front of the bladder. The problem is that the scrotal pump, it's more difficult to put in. It's an unfamiliar territory because, usually we use it only for suspensory ligament divisions. And as urologists, most of us are not doing things in this area. And of course, there's a chance of gland hypoesthesia, penile hypoesthesia, and dorsal nerve injuries. The third approach is the circumcoronal approach. Now, the circumcoronal approach is the one which, we basically commonly use for the hypospadias repairs and a lot of urethroplasties and things. So this is again something which is very familiar to us. It's a very cosmetically appealing incision because, there's a circumcision which is happening alongside. It gives a very, very good access to the distal part of the corpora, the glandular part of the corpora. You can excise plaques along with putting the implant. You can correct curvatures more easily. So of course it has its own advantages, but this is mainly for putting the malleable implants. Although some people are also putting the 3-piece penile implant through this approach. But the problem is that you cannot place a 2-piece implant, which like Ambicor, which has fixed tubings with it, doesn't have any extra length of tubing. So those kind of things cannot be put with the circumcoronal approach. Then again, the fifth approach, which there is basically the perineal approach. Now, this is an approach of historical importance only, because this was done initially for putting the small carry-on sponge-filled implant in the historical time. So now there are basically 4 approaches: penoscrotal, penile, infrapubic, and circumcoronal. Let's move ahead to the steps basically. So first, what you do is you give the IV antibiotic to the patient before the incision is made. Usually it's a combination of an aminoglycoside with a generation 3 cephalosporin. And basically you can choose either general or spinal anesthesia, but I would ask you to prefer spinal anesthesia if it's safe for the patient, because this is the anesthesia where, patient will have a post-operative pain relief as well. So we would, encourage initially beginners to use this frog-leg kind of position where it's easier to feel the proximal part of the corpora as well. And then we remove hair with clippers. We do a rigorous hand washing. We use double gloving. This is a chlorhexidine-based solution which we use. We put in a pre-capped 14 French Foley's. We do an IO-band draping, as you will see, and we can use a retractor like this, which is basically a Lone Star retractor or a Wilson retractor. Initially, people used to use a Scott's retractor. So all of these things work. Now, just going briefly through the steps. So this is how we've prepared the patient with the IO-band dressing. Now we are making this penoscrotal transverse incision. We are developing this incision along with bicautery. And with some finger work, we are basically trying to expose the 2 corpora. Now we have pulled the penis, we have held the penile body from the penoscrotal incision, and we're trying to pull out the penis so that, it becomes easy to find the planes. And now we are putting in the stay suture. So we are using a Vicryl 2O suture here to kind of take the stay sutures like this on either end of each corpora. So this is on the right side that we've put the stay sutures. Now we're making the incision here, as you can see, in the corpora cavernosa. And now we're inserting first a Metzenbaum scissors. Now this Metzenbaum scissors, as you can see, my other hand is stretching the penis straight up so that, there is no crossover of the scissors and it goes straight into the right cavity. And the tip of the scissor is also directed laterally onto the lateral wall of the corporal cylinder. Now I'll go inside and I'll open the scissor up. I will not be cutting any of the tissue. I will just be, gently opening it up, and we will see that in the video again. And now I'm going to sequentially dilate both distally and proximally. And I am going to increase the size of these dilators. These are the various dilators that we use. So we can start from a 7 number and we can go to as much as probably 17 or 18. We not had the need to, but for LGX we can go at least up to a 15. So you should have dilators available till the size of 15 at least, or preferably 15, 16 that is what is available. So now, as you can see, I have ensured that there is no crossover happening. Both the corporal cylinders, they have been dilated well by the dilators. I am taking a length this way. This is my technique, but you can of course take out the corpora, or you can have this sort of a measuring tool. Now this is a tool, which you can just separately use. It has markings on it, so you can just put in and measure the length of the proximal part and the distal part. So this is the two lengths. This is basically something which we call the goal post sign, which means just like in the American football, the goal posts are there. So you will see here that this has been done for the proximal part of the corpora. You can see the lengths are maintained, and they are basically, so they are both pointing outwards because the corpora there are diverging out. So as you can see, my higars are also basically from the inside, they are pointing outwards. And you can see that they're the same length. So it means that we are in the right place, and they're resting over the pubic bone, the skill bone. And now I'm just widening the corporotomy, and now I'm inserting the implant. This is the Shah's implant, which we are inserting. This is how it looks after the insertion. You can see the two corporotomies, and you can see that the penis is quite straight and quite rigid, and probably more than what the patient would be expecting in most cases if you've done your expectation management right. And then you just close in the subcutaneous and you put some absorbable. So this is how it usually finally looks like. There's minimal edema around, and this is a tegaderm dressing that we've placed. Now let's just move back to a video on a 3-piece penile implant. Now this we will just run it forward a little faster because we are already short of time. It's been so much to share that So I hope you can all see the video. Now this is a 3-piece penile implant being done. This is a little older video, so it doesn't have all the same principles as I personally use at this point of time. So we are just basically making the space, as you can see, and we've started the dilatation process. Now this is quite similar to, so we are able to feel the dilator up to the midland. So I have with me one of my very good friends who had come to learn the 3-piece implant, kind of just see it live. And so I don't have my regular assistant here, but I have the company of a urologist. So we are dilating, right? And this is the other corporotomy on the left side that I've made. Again, I'm dilating the left side as well, and feeling that the thing goes up to the midlands, and proximally I'm able to touch the bone. Now I'm going to measure the length of the implant. So this is a furlough inserter tool, which also is a measuring tool basically. And some people use this tool straight away to dilate. Now what we're doing at every point is that we are using the antibiotic solution. Now this is vancomycin and gentamicin based solution. Some people also add rifampicin. Now this is the reservoir that we couldn't show you earlier live. So we are just talking about the parts of the 3-piece. So this is the reservoir. And as you can see below, this is the hemiprosthesis with the pump, the 2 hemiprostheses with the scrotal pump. And you can see they come pre-connected now. Earlier when I used to do implant, they were basically all 3 separate tubes, but now at least the hemiprosthesis and the pump, they come pre-connected. So we are opening this up, and this is a Keith needle. This straight needle is called the Keith needle. And as you can see in this furlough inserter tool, I have placed this needle, and this thread is basically connected to the implant, which you can see, right? So what I'm going to do is I'm going to insert this furlough inserter tool inside. And this is something that you probably would like to see once. Now this has gone in, and at the back end of the furlough inserter tool, there's a pusher. Now when I basically press on the pusher, what it will do is it will make the needle come out through the glands. So now I'm pushing it through, and we will see that from here, from the glandal part, the needle will come out. So can you see this needle coming out? And now we're going to pull this needle out, and then with it, we're going to pull the thread, which is connected to this end of the implant, the glandal part of the implant. So it becomes much easier to insert. As you can see that I am already covering the second cylinder to prevent a crossover with a pre-inserted dilator. Now this is something which is very good for the beginners. That's why I've chosen this video to show it to you. So here the implant has gone in. Now we're putting the other implant in the similar fashion. And basically we will say that here goes the other teeth needle, and basically then we're putting in the implant here. And now we are basically, what we're doing is we're putting the distal aspect of the implant. We're just making it fit more properly. And now we're just going to see if the implant is working. So this is a dummy reservoir. We're using a syringe as a reservoir now. So we have made some, so as you can see, I have made space along the inguinal ring, and I've pierced the transversalis fascia. And now with my fingers, I will be able to feel the back end of the pubic bone. So I will be able to basically rub the back end of the pubic bone. And now I will be putting in the reservoir inside this cavity which I have created. This is the pre-vesical space. This is the place where we normally would be placing our reservoir. So as you can see, the reservoir has already been placed now inside in the pre-vesical space. This is a little difficult to demonstrate because that area is very narrow. So apologies for that. And now we're just testing, filling in the reservoir, and then we're going to just connect the tubings together so that the entire assembly is connected. And then what we'll be left with is just the placement of the scrotal pump in the subdartos pouch. You can see that we're placing the scrotal pump in the subdartos pouch, and then we'll basically be closing our incision after fitting in the tubings together. So there's this is basically a proprietary system that the AMS has to lock the tubes together, and we have to make sure that there are no air bubbles which are there, because that can lead to some sort of a mechanical failure. Now we're just checking the implant once, and as you can see, I'm pressing on the scrotal pump and the implant is really getting rigid. So I hope we are back onto our slides, and let's just talk about some special situations. So the third patient I remember that I did independently was a patient who had come from the US for an implant in India, and basically he had a hernia surgery which he couldn't remember that he had done because it was done about 40 years back, and we had a really tough time in placing his reservoir. So that is when you should know that there are other places where you can put the reservoir. For example, you can place it between the peritoneum and the transversalis fascia. You can place it between the the rectus abdominis muscle and the transversalis fascia. So there are peritoneal locations, epigastric locations, posterior transversalis fascia, like it's shown here. These are all the ectopic locations. If the patient is very fat, you can even place it, superficial, just below the fat. So now our surgery has been done, our patient is doing fine. Now how do we manage the patient? So I want to talk to you about drains also. So whenever we feel that the bleeding is a little too much, when you're closing, you feel that the blood is coming up again and again, it's a good idea to put in a drain and remove it the next day. We've not seen any infections rising because of the drain being there. We usually keep the patient on IV antibiotics, again, the third generation cephalosporin with aminoglycosides for 48 hours. And if the patient feels any problem, especially when we are doing a 3-piece, the scrotum is being handled quite a lot because we are putting the scrotal pump. For a malleable implant, we don't need to worry too much about the scrotum, but for a 3-piece implant, we do have to worry about the scrotum, so we can put ice packs. We review the dressing in 2 to 3 days. We counsel the patient for expectation management, again, that this is how the surgery went, this is what would probably be happening. We ask the patient to wear the penis over the abdomen for 4 to 6 weeks. Now you have to understand that whether it's a malleable implant or it's an inflatable implant, the implant has to be placed on the abdomen for some period of time because we want the entire system to heal well with the implant in the inflated position, so that the pseudo capsule which forms is also quite big enough to give the best size to the patient. The patient can start to cycle the implant, deflate and inflate after 2 weeks anytime, whenever he's comfortable. And sexual activity usually can be resumed in 4 to 6 weeks. Usually we tell the patient that it is resumed in 6 weeks so that the patient is not too excited, or again, this is a part of expectation management, but practically after 3 weeks, patient do start sexual activity as well. So we ask the patient to follow up at 1 week and 4 weeks. Now, let me just talk to you briefly about what are the complications that can happen with this prosthesis surgery, because of course it's not a very easy surgery. I would say it looks very easy, but there are so many things which can go wrong, and I've learned it the hard way that uh, you have to be very careful. Probably you should have a mentor who can guide you about going about the surgery. So for the academic point of view, we talk about intraoperative complications and post-operative complications. Now, intraoperative complication is urethral perforation. So basically, sometimes when you're putting in the dilator, now inside the corpora, and if the dilators, this part is more medially, then you can of course very commonly injure the fossa navicularis. This is something which happens very commonly in the western side. This is one of the commonest complications. Practically what I have seen more commonly is crossover, which means that you're dilating the right side of the corpora, and because the penis is all not kept straight, or it's just moving around, hypermobile, so you end up going through this dilator into the left side of the corpora cavernosa by piercing the intracavernosal septum. That's called crossover. Then you can have distal perforation. If you are too aggressive in putting in the dilators, then what you can do is you can perforate the distalmost part and end up going into the glans. There can be some residual curvatures which can remain, and sometimes the glans can become floppy, which means that the implant does not reach to the most distal part of the corpora cavernosa. The post-operative complication, of course, is the most common is infection. Infection, the rate usually is cited in literature as 1 to 3%. Now, this is a rate for the more complicated three-piece penile implants, I would say. So, practically speaking, the infection rate of a malleable implant would be a little less, maybe less than 1% for most typical penile prosthesis surgeons who are high-volume surgeons. Perforation can be there in the post-operative period as well. The implants parts, the three-piece implant part can erode into the viscera, maybe near the intestine or into the bladder. This is something which is known to happen. What has happened with me as a complication also is migration of the pump of the reservoir itself. So because the reservoir is being placed deep in the prevesical space, if there's excessive cuffing, which happened in one of my doctor patients who were flown from Indonesia, is that the thing can come out, especially because in the inflated state the reservoir also it's not completely filled. So if there's vigorous cuffing, sometimes the reservoir can come out and migrate outside and lead to autoinflation. Sometimes you can have lax penis because the suspensory ligament has worn out and the patient is able to move the penis here and there and is not satisfied. Then there can be a cylinder aneurysm, because we know that the cylinder, the inflatable implant cylinders, they have 3 layers in them, and now the Rigicon has 4 layered implant as well. So these 3 layers basically, one of those layers can break and then it can pop out as an aneurysm, like a diverticular sort of a thing. And this is one of the long-term post-operative complications. There can be some residual curvature which can remain. There can be some hypoesthesia which can remain. One of the the most difficult complication I would say is glans necrosis. So patients who are immunocompromised, diabetics, or where a circumcoronal approach has been used, or aggressive dilatation has been done in the distalmost part, you can have glandular necrosis because the blood supply is compromised. And sometimes the pump mechanically, it may fail. So it has been seen that the average implant, 80% of those implants will be working well. The three-piece inflatable implant will be working well by 10 years. And as the time passes, there would be mechanical failures which will start to pop in, which will require a revision of the implant. So I'll just show you a few case scenarios. So this is a distress call that we got from a colleague who was doing an implant. It was a 2-piece implant. It's a 36-year-old gentleman. Now the surgeon was not able to insert the second rod. I have a video for this as well. I'll just show you what went wrong here. So when we went in and we recorded this, this is what we saw. So there was one 2-piece which was already in situ. Now when we are trying to make space with the dilator for so here the surgeon has not already placed the dilator in one of the other corpora. So that's where a new surgeon can go wrong. Now we are trying to put in the dilator here, as you can see. So now when we try to put in the dilator, what is happening is that, so it's going somewhere else. You can see that it's not going laterally. There's a crossover which has taken place. And this implant has come to this side and the dilator probably is trying to now make space into the other side. right? And as you see, when we pull it out, this implant is also moving along with it. So this is one of the cases where there's a crossover which has happened, and you have to realize this before it's too late. Let us get back to the presentation again. So this is one of the cases. So now what we need to do is we need to take this out, put in the dilator again, and then try to reinsert the first part as well. So then you can correct it intraoperatively. Now this is one of the second most common dreaded complication, which is infection. You can see that this 30-year-old gentleman presented to me with this problem. Now here his implant is trying to come out. Probably it was a distal perforation which was unrealized, and there is pus from the suture line. And slowly, because of this chronic infection, the implant is trying to erode out because it's a foreign body and the body is not accepting it. Now, this is the 42-year-old diabetic patient who is been changing hands with the surgeons, and basically had a floppy glans, which the surgeon could not counsel him for. So he ended up getting a glanspexy and a glanduloplasty for his hypermobility, and then he started developing itching because of the sutures, and eventually one day he had bleeding, and we can see that this Shah's penile prosthesis is seen coming out from the surgical site. Now this requires immediate removal to prevent infection to the rest of the body. But these are some of the other things I wanted you to see. This is again I would say a crossover which has taken place, but not realized intraoperatively. So post-operatively, we are seeing this crossover. And this is a glandular necrosis, and this is atrophied corpora leading to a hypermobile gland. So this is something which can be commonly seen. So I think there is so much more to say, and I'm quite excited to share all this with you, but I think we have to put an end to it because my hour's time is over and we need to move into the questions. So thank you so much everyone for being there, for listening throughout this talk. And I hope that, I could at least put in a spark inside you to become a prosthetic surgeon, and you could appreciate these live implants as well, which were around. Just to make it more practically appealing, I have this small model wherein we have a 3-piece implant. So basically this is how the scrotal pump works. So you can, if I keep pressing the pump, eventually what will happen is that the penis will start to become erect. Now this model, of course, it's just a model. It takes many more pushes than an implant, but you will find that eventually it will become erect. And then there's a button here. When you press, the implant will basically just become flaccid again. So I hope that I've done justice to it, and then we can take over the questions if Arun sir allows.
Raman, we'll take few questions from the chat section. I'll just put one by one. Now the first question is from Jivtesh. What is the function of rear tip extender and why is it detachable? I think you covered it, but still would like you to answer, Jivtesh.
Right. So as we would know, sir, all the implants that we can see, they are rear tips. They are not well modified. They have some sort of a mechanism which requires protection before it can perforate into the proximal part. Secondly, sometimes, when you're sizing the implant, sometimes what happens is you cut a little too much, or you realize that whatever you measured was not right. So that's when the rear tip extenders come in handy. For example, if you feel that, you've cut a centimeter more than what you wanted to cut or what you had to cut. So what you can do is you can choose a rear tip extender, which is a little longer, and that can save the day for you. The other thing is that, all these AMS implants and other implants, they are available in prefix sizes, because the malleable implants you can cut. But these implants, they come in particular sizes. So they have sizes as was shown in the chart. So if it was an 18 centimeter implant which is available, and your length of the penis inside is 19 centimeter, then you can put a 1 centimeter rear tip extender. Also, for example, it was 20, then you can use a 18 size and put a 2 centimeter rear tip extender. And if you by any chance, God forbid, you don't measure it correctly and you feel, that this glance is now floppy over this, and you want to increase the size further, then you can remove that 2 centimeter rear tip thing and put a 3 centimeter rear tip thing, and that again saves the day. So I think it's a boon that we have rear tip extenders with us. And for certain implants like the ZSI, we even have a front tip covering. So, things are evolving, sir. Arun sir, can we take the next question?
Yeah. What is the cost of Dr. Shah's prosthesis?
So I would say, this is not the right platform to talk about cost per se, but I'll give a rough idea. This is about 20,000 rupees from the company. And if you talk about a Boston implant, it is about 1 lakh plus GST. And if we talk about a two-piece implant, it is somewhere around a quarter to 4 lakhs or 3.5 lakhs. And if we talk about a three-piece implant, it is based on what model you choose. If it's a CX model, which is the standard model, it's about 6.5 lakh rupees. If we choose a CXR, it is 7.5 lakh rupees. If we choose a LGX, it's about quarter to 7 lakh rupees, something like that. Of course, these keep changing based on dollars and international currency.
Next question
So that's
from
the cost of
Dr.
the implant.
Kaushal. Yeah. So question from Dr. Kaushal. Is there any training program for penile implants in India? So he wanted to have a little more knowledge about where he can
So, sir, I
see the
would recommend.
opportunities to see.
Right. So basically, a formal program fellowship is run by Dr. S.S. Vasan. It's affiliated to the Rajiv Gandhi University of Health Sciences. Otherwise, informally, yes, there are a lot of people who will be willing to teach. And I would recommend to go to the masters, Dr. Rupin, Dr. Vasan, and many other leaders who are doing penile implant. If they just want to go just for the experience of penile implant surgery itself. And of course, if there's any guidance that they need from me, I'm always there to help. Apart from that, internationally, there are a lot of avenues, of course.
A question from Karandeep. In the immediate post-op period, he's talking about inflatable penile prosthesis, whether the implant is kept inflated or deflated. But it's a two-piece or three-piece.
I think we did cover it, but we have to basically keep the implant in an inflated state, because what we want is that the pseudo capsule which forms around the implant, that should be as big as possible, to prevent further contraction of the penis. And once it's kept for 4 to 6 weeks like that, then the pseudo capsule will form in the largest possible size, and then we don't need to worry about the penis being deflated most of the times. So we keep it in the inflated state for 4 to 6 weeks, and during this period, the patient is asked to wear the penis on the abdomen, and we usually strap it up with the abdominal binder or something which like a body contourer or something. These work very well.
There's a question from Dr. Shishagiri. How do you manage an on-table distal perforation, or say a perforation into the glands on table?
Sir, I think that also depends. The answer also depends on what kind of an implant we are using. For example, if it was a Shah's implant, then the beauty of this implant is that we can just stitch it with the corpora anywhere. So we can take in a bite from the corpora into the implant and out. So the thing doesn't move any further back or front. So easy way would be to just make sure that you follow the same length as the other side's implant is, and then fix this right there, and be done with the surgery. So the perforation will heal itself, and the implant will not move further, and then eventually after 6 weeks everything should be all right, and the patient should be quite good to go. When it comes to the inflatable implants, what usually happens is that we can again do a similar maneuver. We can fix the area from which the tubing come out with again some sutures, and that can keep these implants also fixed in the place in case we've done a distal perforation. However, in case you've done a urethral perforation, then you probably would either have to just abandon the surgery, tell the patient whatever has happened, and plan for another good day, a luckier day where you would want to go in. Or what has been done is that you can make a hypospadiac meatus and work around it. That will be a more complicated scenario beyond the scope of probably this talk.
Okay. Raman, a very interesting question. This is from Dr. Nikhil. So he's asking a patient who is a neurogenic bladder and the paraplegic, and as a collecting device to be more comfortable fitting around the penis, whether we can have a implant. And he is shared that he has read this indication very recently. Your opinion on that? Any experience?
So basically, we've done implants in patients with neophylasis, and basically also this is a special scenario, so because the sensations are not as much. So if we use a very hard implant and there is aggressive intercourse and patient is not able to realize because there is no pain, then there are chances of malleable implants actually coming out from the or eroding out. So what is typically recommended in patients with these kind of situations where there is a neurological deficit is that we use inflatable implants because they are softer, of course. And malleable implants, there are specific kind of implants which are available. For example, we can use either a non-hinged soft penile implant from Dr. Shah's, or we have the one available from ZSI again, which is specifically made for paraplegic, which is very soft. So it gives substance to the penis, and it can allow intercourse by holding the base of the penis and using a lot of lubrication. But they are more supple and they would be much safer in these patients because they've already suffered so much and they would not know when the implant is eroding out. So those are the options in this. First is to go for an inflatable. Second is to go for a softer implant which is specifically made for paraplegics.
Raman, this is the final question. What is the S-shaped deformity and supersonic deformity?
Right. So basically, whenever we are putting in an implant which is more than the size of the corpora itself, what will happen is that when we force through, then the implant would kind of try to fit in. So what will happen is it'll buckle like this. If you can appreciate what I'm trying to say, it has to fit into a particular length. Now its length is more than the length of the cavity in which it has to go, so it will buckle like this. Usually this will happen when you've used a very low girth implant, which means if you use a thinner implant, then it will still go in because the cavity can allow more girth to be accommodated in view of length. But if you use a thicker implant, then you will not be able to fit in anyways. Then you will probably either perforate or you'll not be able to fit in. So when you're using a thinner implant into a cavity which is smaller than the length that you measured for the implant, then there is this buckling which happens and then the penis becomes S-shaped. The supersonic deformity is basically a deformity where you have put in a shorter length of the implant. So that what happens is, we did mention about the hypermobile glands, but SST is a little separate from that. So supersonic deformity, the glands will droop down and basically you will be able to feel the rods from above and below, and the glands will be hanging separately like this. So what you need to do in that case, if it is actually a supersonic deformity and not hypermobile glands, and if you allow, we will explain the difference between the two, then you will have to remove this implant, put in the right length of the implant to make things work. On the other hand, there's another situation which I referred to in the last slide, which is called as a hypermobile glands, where what happens is that because of the prolonged nature of the erectile dysfunction, the corpora basically they start to shrink because the blood is not going in them and they are atrophying. So the corpora which are normally usually up till the mid glands, they would come a little down, maybe at the level of the base of the glands. And then what happens is that whenever you put in even the right side size implant, the glands will still be able to move above and below it, right? So it is hypermobile. It is not drooping down like an SST where the length was less. Here the length is adequate because it's fitted well into the corpora, but still because the corpora have become shorter than the usual and not reaching mid glands anymore. So now the glands is moving around, and you can do a simple glanduloplasty or a glandulopexy with sutures, and you can try to fix this thing up. For example, there was a case scenario which I described where this glandulopexy was done. So that's the way to manage this. And for us, for S shape, again, you have to remove and fit in the right size. Basically, it's all about sizing both these two deformities.
One more question has come just now. That question is from Dr. Surad. Any experience of putting penile prostheses in patients with pelvic fracture uterine injury, or say who are doing CAC or have been operated for pelvic fracture?
So fortunately, we do have experience around it, sir. First thing, there are two things I would want to convey as a message in this. That one, you have to make sure that the urethra is stable before you go for an implant. If the patient is on CIC and if you feel there are strictures, you manage that first with the urethroplasty. I think that will be the best thing you can do for this patient, because we don't want this patient to end up with a retention or some sort of a problem and he going to somebody else and a surgeon or somebody trying to help him in the emergency and then perforating the urethra and going into the implant and then infecting the implant. So the urethra has to be stable one. Secondly, is specifically in PFUDD, where you have traumatized the proximal corpora, you should get an MRI as far as possible to see how the corpora is, because many times you will not be able to easily dilate the proximal aspects. You may end up perforating them, so you have to be very gentle. Luckily, with these kind of implants that we have, the proximal part is thinner, so we don't need to over aggressively dilate the proximal part, and we can always taper them. But then it becomes a challenge to dilate those corpora, and we have to be very, very careful, uh, very wisely and gently dilating the two things. So this is something I would like to clarify. And if the patient is of an unstable stricture type, just tell him if there's retention, ever go and get an SPC. Don't ask somebody to try and do OIU or dilate or things like that.
Raman, one more question has come. What is the ideal timing of prosthesis in post-pre-operative erectile dysfunction?
Right, sir. So basically, around priapism, there are still debates going on. But of course, the best time, if the patient agrees, is to do it after 72 hours, because we have to make sure that there's actually going to be a permanent erectile dysfunction after that. So if any patient comes early in priapism, we can of course save the erectile tissue. But if 72 hours have already passed and you can take a biopsy just for medico-legal purpose to document there has been necrosis, then you should medico-legally be safe to offer him an implant surgery. The other thing is that, if somebody has had priapism earlier, then up to, I would say, the next 2 to 3 months would be a good time to, do the surgery, because at that time, there will only be corporal edema that we will encounter and not corporal fibrosis. But beyond 6 months, definitely, I have done a case which was a couple of years old, priapism, and I had a hell of a time. I had to do a distal corporotomy and put in a guide wire through which I had to make shift and dilate, and then we could give him the best girth of 9.5 only. The patient was satisfied, but it becomes challenging after priapism, definitely. So ideally, anytime after 72 hours of priapism to the first 3 to 6 months is a good time to do the surgery. Earlier the better, sir.
And what about pelvic fracture urethral injuries? If your patient is having ED, how many months after that?
So, sir, after PFUD, first thing is that we have to manage the urethra, which itself will take some time. And by that time, I'm sure by the time his urethra is managed, he should be okay. His stricture should be stable. So we may give him 3 to 6 months to see if his stricture is stable and things are okay before we can give a green flag to go for an implant surgery.
Raman, one more question. This is from my end. In which age group, which decade of the age group you will find the patient?
Arun, you'll have to tell PGs to log in. It's 8:25 for the quiz.
Yeah. The link for the quiz is on. It's 8:25, and please, you can just open the link and start with your quiz. Raman, in which decade of the age group you will see the patient volunteering themselves to get the penile implants, whether they are young or whether they are coming after 50?
So, sir, unfortunately, the cultural foundations around Indian sexuality are governing this answer. So it is a very biased answer, of course, because somehow I find that Indian men feel that even if they don't have sex after 50 to 60 years of age, it's quite okay for them, because women in our country don't demand sex from Indian men after that age. I think that's the reason behind it. In the Western side, there is ingrained in the women that they need sexual intimacy till much beyond. So I have operated on 85-year-old men from the West coming here for an implant surgery. That's a much more common scenario than an Indian 50-year-old man coming in and getting an implant surgery. And I'm very sorry to say this, but this is how our culture has been. This is how we've been brought up. Maybe that's why. So right now, the patient, the kind of we get is somebody around, say, 35 to 55 years of age. And usually we do get a lot of diabetic patients. We do get patients after radical prostatectomy. So these are things which I was thinking would, come up as questions, how to deal with radical prostatectomy and all, but they've not been asked. But anyways, so this is the age group where we are usually working. That's the active age group where patients are coming to us.
Another question is, how in your practice, how many patients you have seen continuing the self-injection, whether it's a biomix or a prostaglandin or caverjector, before going for a penile implant, sir?
So, sir, I would say that, this is something which is not in the textbook, but just out of my personal experience, and everybody may have a different experience around it. Somebody who hangs on with intracavernosal injections for more than a year usually keeps using it. Basically, that's what I have seen. So we have actually a separate clinic wherein patients would come and, they won't even see me. They would just ask my staff to make trimix for them or biomix for them, and they would live on with it. So you will end up making a clinic. A separate staff would be there who would be teaching it under your supervision and managing those patients. And so if you're doing well, then I think you have a separate clinic for ICI injections. That's a possibility. But yes, for patients who, there are certain group of patients who are needlophobic, and for them, we can of course offer an implant. But I have seen a reluctance somewhere in Indian men to go for an implant, especially after robotic surgeries, because I think the numbers are too high, but what we're doing as numbers is very low. So either the awareness is not there, or if the awareness is there, the acceptance is not there. Maybe the demand for an erection is not there.
As you said, they wouldn't want to think about sexuality after they've had the prostatectomy done. After a robotic radical prostatectomy, they would have passed that time of thinking about sexuality at all.
Absolutely.
And branded as he's a cancer patient already. So all those things are gone out of his mind.
Dr. Keshav, there is I'd like to mention at this stage that right now also we have a patient operated 3 days back after radical prostatectomy, and people who were not um, doing sexual activity before that, and when they are asked questions and then they know that they can do it now, so they prefer to undergo operation, and we have operated patients. The current patient who is admitted, he is nearing 80, and the other patient, university retired professor, he was 76 plus, and ministry we had to take because he was getting free implant 3-piece, so we had to get special permission. He was so educated and he was questioning. So now more and more in India also, the age is not so much important, and also it is important, but it is losing its importance. And other thing is
very small percentage, sir. Very small percentage of patients.
No, other thing is when we are when we are talking about radical prostatectomy, is when most of the patient had combination of incontinence and ED both. So by the time incontinence settle or you find a solution in Indian scenario, that the need for the implants keeps on coming down. But yes, definitely the people who are young who get early detection of the cancer, they're fairly localized. You do nerve sparing, or you keep the you can say a good continence, 6 months, 3 months, and they have only ED as a component. Probably they are very good candidates, and they do very well also. Yeah.
And also there are patients where you are putting the sphincter also and implant also.
Yes, exactly. So this becomes a little twin condition. Raman, while we are talking, I got 2 questions quickly. I'll take it. The role of vacuum therapy in post-prepism implant. Post-prepism, prior to implant.
Right, I can appreciate
therapy. And the second question, any tips to conceal erection after Shah's prosthesis?
Right, so vacuum erection devices, they do have a role somewhere, in the sense that, to maintain the length loss. I think it is good if we can encourage our patients who are waiting for an implant, maybe somebody who's even been explanted once because of infection. There, to maintain the length, we ask the patient to at least try using the VD at least twice a week. That's what we follow. And usually we give them a motorized VD because the manual VD, it's a little cumbersome to use. And at my clinic, we give it for rent. And then, the patient can use it, give it back, we ETO sterilize it, and that's how the program runs. So right now I don't have any vacuum erection devices. They're all with patients. That's again a good good thing. The other question is to how to conceal the malleable implants, specifically a Shah's implant, which is not one with a memory. Usually, we counsel the patients that they will have to maybe accept this fact that they will have to conceal it somewhere. So tighter underwears are a very good answer. Body contourers which are available are very good answers. But what I am coming up with is a special sort of a strap device, because the point is that whenever you are concealing it over the abdomen on the sides, it just feels too warm, to wear something extra to cover it. So we're coming up with some sort of an arrangement which will allow air also to, it'll be a breathable device which will allow the implant to remain on the abdomen easily for these kind of things. But I would also like to comment on that if you've chosen the hinge in the right way, because we talked about the implant having a hinged area. So if you use the hinge right in the right place so that it extends from the root to the pubic symphysis, then usually patients are easily able to conceal it even in the downward position by just wearing a V-shaped tight fabric underwear, or maybe one size smaller than what they would usually want to wear. And patients who've got it done, we've not seen anybody. I would say very small percentage of patients complain about concealability. Most of them accept it, and they are doing well with it.
So, Raman, before I hand over to Dr. Keshav and Dr. Ajit for concluding and closing remarks, let me say this was a masterly presentation. So nicely, the indications and contraindication for implant has been covered, and probably the types of implant. It means I don't know whether agents will how they are found. It was just like a smooth flow of a river. If they go to Campbell to read it without this, it would have been very difficult. Now I think the job is much easier, and the videos, the 2 or 3 videos which you showed, I think have probably, I am very sure, would have got all the concepts correct. How to place it, how to dilate it, and the technical challenges, as well as probably the key steps. I think which you have covered, especially when you were talking. I think they were very important, and probably we could understand much better, and probably the residents would have also noted, and they were very important, and so nicely put up all the pictures of on-table complication and the post-operative complication, the masterly presentation, an excellent webinar to watch. And with this, I hand over to Dr. Keshav and then Dr. Rajiv Sood for the concluding and closing remarks. Thanks, Raman. And I'm feeling very privileged to be part, seeing all this from beginning to the end. Very nice presentation. Yeah.
Thank you so much.
Thank you, Dr. Chawla. Thanks, Raman, for your wonderful talk. I sat through completely. We really enjoyed it. I think it was very informative for the residents, and it's stimulating for them to take up andrology. Not many people are opting to take up andrology. I think it's a very lucrative subspecialty which people are not tapping. It's more lucrative than endourology or uro-oncology, but people have not understood it. I think it was inspiring talk for all the residents. Thank you very much for your time, and it was good. I hand over to Dr. Rajiv Sood for his concluding remarks.
Thank you for the opportunity.
One minute, Dr. Rajiv. I think Dr. Keshav remarked about andrology. I think last webinar also we are repeatedly telling, don't ignore these specialties are very important. They are related to quality of life, and the results are very good, and a one-time patient is your permanent patient. And probably this is a high time the residents who watch this webinar, they develop some interest, develop some what you can say collateral reading, or maybe after their residency is over, they work with some master craftsman, or they shadow some person like you, and probably some proficiency, and they're on their own. It doesn't need a structured fellowship for 1 year or 2 years. You need to follow a good person who has got a skill, and who is knowledgeable, and who can teach you well. That is more important, and it's a high time people start thinking and about the URS and PCN and other TRP and bipolar and laser, and come to these specialties. Over to you, Dr. Rajiv Sood.
Thank you, Dr. Arun Chawla and Dr. Keshav, and special thanks to Dr. Raman. So beautifully, in the concise way, in this limited time, he has highlighted each and every aspect of penile prosthesis and its use and its types and its complication and what are the expectations of the patient. Main focus is on quality of life. I'll tell you that before the advent of Viagra, sildenafil, 2 decades before, it was not much talked about subject, and it was not considered to be that important also. But things started changing. USI has done a great service to this specialty, and we had a big master class in 2006 where 7 implants were different techniques were semi rigid, two piece, 3 piece. They were operated, and after that there was a World Congress also where it was included, and now subspecialty is created and is nurtured by Urological Society of India. And also earlier, for the resident point of view, this subject was, maybe they were not considering it very important, but after that we have started radical prostatectomies, interest in the erections. You know that there is very little literature from India about the radical prostatectomy erectile function and post radical prostatectomy erectile function. Published literature is not that much available, but have been stalwarts in our country, Dr. Rupin Shah and all, who have given a new impetus for this whole subject. And a society was created. After that, men's health specialty created, and then not only limited to that, now in the Euromed program, in the cadaveric workshops in Ramaiah Hospital, we have participated in the penile implants, and we are in the cadavers and practicing that, and we were planning very soon that in this session also, but because of COVID pandemic, it is getting delayed. So residents are having today gala time in the education about the subspecialty. The subspecialty, which was when included in the annual conference, and I'll share with you, it was one of the maximum attendance in the USI annual conference in these sessions. So this is not a thing where interest is not there, but the drive was not there, which is now provided by this subspecialty. This subspecialty, men's health and andrology, has done wonders in the last year also. In the under ISU, under various formats, hands-on workshop, cadaveric workshop, lectures, and all. And when we have the teachers like Dr. Raman Tanwar and the people interested, I think it will go to the new heights, and we will be at par with the global excellence in this subspecialty and in this field. So thank you very much for connecting to this program. And also this program is preserved in the archives also. It can be visited, and we have earlier videos also of masterclass and all. We'll try to put that also in the archives, so that our all residents who are thinking of taking up it as the career opportunity and the subspecialty, they can be benefited. Thank you very much, everybody, for the time being, and we will be meeting you soon with this subspecialty also and other subspecialty programs which are scheduled this week also. I'll for till that time. Goodbye, good night for today. Thank you, Navneet, our office, USI office, and the entire council, which is so helpful, especially Dr. Keshav Murthy and Dr. Malkarjun. And of course, Dr. Arun Chawla, who is taking so keen interest in the development of ISU activities. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, Dr. Keshav. Raman, just your appreciations and thanks are pouring in the chat box. just to make you aware.
Thank you, sir. Thank you
Thank
for all blessings from Sood sir,